Good afternoon, and welcome to today's program titled Patient Misidentification in Healthcare, Ponemon Institute Report, presented by Imprivata and hosted by PSQH. My name is Jeff Connick, and I'll be your host for today's program. Our program today will be 60 minutes in length. The first portion of the program is a presentation, followed by a Q&A session at the end. Today's program is being recorded. Before we get started, I'd like to take a moment to review the web conference platform. First, to ensure that you can see all of the content for the event, please maximize your event window. Second, be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Third, at the bottom of your console are multiple widgets that you can use during the program today. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program at the end. Should you experience any technical difficulties during the program today and need assistance, please click on the yellow help widget at the bottom of the screen that has a question mark icon and covers common technical issues. We're very pleased to offer this free educational opportunity by Imprivata. Before we get started, I'd like to now introduce our speakers for the program today. First, Dr. Larry Ponemon, founder and chairman of the Ponemon Institute. Next is Christopher McKay, RN, Director of Nursing and Clinical Workflow Specialists at Imprivata. And finally, last is Justina Evlo-Yildiz, Senior Product Marketing Manager at Imprivata. Finally, before we get started, note that an on-demand version of this program will be available approximately 1 day after the completion of the event and can be accessed using the same login link that you used for today's live program. Also, a copy of today's presentation is available in the Resources List widget, which is located in the lower left of your screen. Before I pass the program over to the speakers, I want to go over today's agenda and cover our very first polling question. The agenda for today will go over the results of the 2016 National Patient Identification Report that was hosted by the Ponemon Institute. We'll then go over patient misidentification causes and challenges and potential solutions to those issues. Now for our first polling question. In a moment, you will see the question and the possible answers appear on your screen. Please select the appropriate answer using the radio buttons on the left side and hit the Submit button at the bottom of the polling window. Note that you may need to use the scroll bar within the window to see all of the options and the Submit button. You may select your answer at any time when reading the question. Your results will appear along with those of the entire audience. Our first polling question is, have you seen an increase, decrease, or no change in the amount of misidentified patients receiving care in your facility? And those, again, the answers are increase, decrease, or no change. So again, have you seen an increase, a decrease, or no change in the amount of misidentified patients receiving care in your facility? I'm going to give everybody a moment to answer before pushing the results to the audience and turning things over to the speakers. All right, let's go ahead and take a look at those results. And as you can see, 31% say they've seen an increase, 10% have said they see a decrease, and 58% have seen no change at all. So with that, what I'd like to do is go ahead and hand the presentation over to Larry Ponemon. Larry, the audience is yours.
Thank you very much for that wonderful introduction. And folks, I really appreciate your interest in our research and attending today's webinar. Everything we're presenting to you today will be available on the PowerPoint slides as well as a full copy of our research report. So the good news is you don't have to take notes and really struggle. Just sit back and relax for the next 55 minutes or so. The title of our recent report, sponsored by Imprivata, is the 2016 National Patient Misidentification Report. And again, this is a research report independently conducted by my organization, Ponemon Institute, which is a research organization. It's been in existence for over 15 years, and our focus, linear focus, is on security, data protection, privacy, and other related fields. Okay, so let's start off here. We basically know that there's a serious problem in many healthcare organizations that relate to patient misidentification. And this results, of course, in medical errors, financial losses, as well as a negative impact on the overall patient experience. In the study that we're going to present to you today, it involved objective responses from nurses, physicians, IT practitioners, and those on the financial side of healthcare organizations. Specifically, we're going to look at four general areas of research and findings. First, the root causes of patient misidentification. Number two, the impact on medical errors and patient safety. Number three, the impact on hospital revenue. And then the good news is potential solution to the misidentification problem. So we will now jump into the research. Drum roll, please. Next slide. So this is a researcher will love this table, but I'm sure that if you're not a researcher, you're probably saying, what does this tell me? Well, in total, we had 503 qualified respondents. Our sampling frame was nearly 10,000 people, a U.S.-only study, and the 503 respondents, about 55% of those folks that were or are clinicians, physicians, nurses, and so forth. The remaining folks were folks in the administrative side of healthcare organizations as well as the IT side. So if you read a copy of the report and you want to look at the details, the breakout, it is presented. I think we might even have time to go through some of the organizational demographics as well. The response rate, though, of a 5.2% is really high, and we're very proud of that fact, so it's a good quality sample. So what are the primary root causes of misidentification? And this is the clinical audience of the respondents who are clinicians, like my friend Christopher. So number one, registration mistakes are the number one primary root cause of patient misidentification, according to our study. And what are the root causes? Well, to start off with, incorrect patient identification at registration, time pressure when treating patients, insufficient employee/clinician training and awareness, too many duplicate medical records in the system, registrar errors or human error, turf or silo issues across departments and workflows, inadequate safety procedures, over-reliance on homegrown and maybe obsolete identification tools, and patient behavioral issues, in other words, misinformation on the part of the patient, and then other. So you notice the big three: incorrect patient identification at registration, time pressure that we find ourselves under, and insufficient employee clinician training and awareness. Christopher, I have a question for you. In your experience, does this list seem right, or do you see things differently as a clinician?
I have to say that is really comprehensive as far as the list, and I do think that that the rush to get a patient through in this day and age is really kind of forcing them to hurry through that registration process. So I can see that being a huge factor at the 60%. I agree that these are some great root causes for where it all starts, where it can go wrong right from the beginning.
Well, thank you, sir. Appreciate that insight. If we go to our next slide. The next slide looks very similar to the slide we just presented, but it's different because these are the folks on the finance side, the CFO organization, accounting, budgeting, treasury, and so forth that exist in the healthcare organizations that participated. So we also find that financial leaders cite registration mistakes as the number one primary root cause based on their view of the organizations they serve. And again, what's the top list? Incorrect patient identification at registration. Time pressure now is number two in treating patients. Insufficient employee clinician training and awareness. Too many duplicates. Registration error or human error. This is an interesting one, by the way. Turf or silo issues across departments and workflows. Inadequate safety procedures, over-reliance on homegrown, obsolete, and patient behavioral issues. What this tells me is clearly there's a nice alignment between these two groups. Whether you're a clinician, you're in the administrative arm of the healthcare organization, basically seeing the same problems. Okay, let's go to our next slide. So first I have to tell you what these percentages mean. Again, I'm a research wonk, so I kind of get into the details. But these questions were measured using a 10-point scale from 1, this never happens, to 10, that it basically happens all the time. And so if you think about that scale, 1 to 10, a high response, something that's kind of trending to happening all the time, is a 7, 8, 9, or 10 response. A low response would be a 1, 2, 3, or 4 response. In the middle, the 5 and 6 is just the median or mean response. Okay, so we're looking at the high response, 7+. So having a hard time finding the chart or medical record for a patient in your care, that leads to patient misidentification. 68% high response. In other words, trending to happening all the time. Searching or querying a patient and finding duplicate medical records for that patient, 67% high response. Pulling up the wrong record for a patient because another record in the registration system or EMR has the same name and or date of birth, 61% basically provided a high response. And then finally, the wrong record is associated with the wrong patient because two patients share the same name and or date of birth, according to high response at 56%. So these are things that are really nasty, but they seem to happen pretty frequently according to our respondents. Again, Christopher, what's your reaction to these results?
I see this as a risk, and I do think that there's the human error, but then the fact that there's also people's names that are very much the same, and that's recently just in the news about that, about the same name being the same, John Smith and John Smith. Unfortunately, they didn't have the same CT, and accidents happen. And this gentleman ended up losing a kidney over it. So these are real life situations that need to be looked at.
Yeah, I don't want to lose a kidney, by the way. I like having two. Okay, let's go to our next slide. Okay, this is a nice simple graph for a change. Have you ever witnessed or known of a medical error that was the result of patient misidentification? And we got this whopping response. 86% of respondents to our study said they have either witnessed a medical error or know of a medical error because of misidentification. So 86%, almost everyone in this study, basically said it has happened to them. Does this number shock you, Christopher, or is it just... you're a clinician, so maybe you see it differently. Yeah,
no, I'm still practicing in the ED, and I have to say that I've come back into my treatment area and said, where is Mr. Jones? And they said, they just brought him the chest X-ray. I'm like, he's not getting a chest X-ray. And because if someone doesn't look at an armband and they misidentify him or don't ask, these things happen. That's a small degree. Again, as we talked about just a moment ago, someone having surgery and having an organ removed because of misidentification is catastrophic. So yeah, 86%, I can see it in the different degrees, and we'll talk about some of those clinically and how they have impacts on you. But yeah, that number doesn't surprise me. It happens, and to what degree we'll get into a little bit more later on.
Thank you for your insights. It's great. Okay, so now this is kind of something that's more on the positive note. Positive patient identification can reduce overall medical errors and adverse events. 77% of our respondents agree that positive patient identification could reduce medical error. What's really interesting is you look at the scale from strongly agree to strongly disagree, and if you add 50 and 27, if my math is correct, it's 77%. Look at the strongly disagree as 5%, 8% disagree, and people are in the middle at 10% and unsure. So the overwhelming majority of respondents see this as a really good thing. And you'll notice in brackets we say biometrics. That's an example of positive patient identification. What percentage of denied claims, and changing gears a little bit, result from inaccurate patient identification? And basically we ask that question and using this probability scale from less than 5% to more than 70%. And doing a very simple calculus on the range that we provided here. We calculate a 35% of denied medical claims resulting from patient misidentification, which is a huge number. So if you basically are concerned about denied medical claims, you need to do something about patient misidentification. And some of the other in the report that you will soon receive, we basically try to calculate the cost of just reworking claims because of these claims being rejected. And on the average size hospital in the United States, I think we came up with a number like $71,000 or $72,000 a year. So these costs can be very substantial. And let's go to our next slide. How significant do you believe denied claims for patient misidentification has on the hospital's accounts receivable? We just talked a little bit about this, but 65% say very significant or significant. Not significant is only 14%. So these people are probably drinking wine as they were doing the survey, because I think it's pretty clear it should have, and it does have a very significant impact. I think most accounting and financial people know that as a fact. Now, let's talk about something positive, the benefits of positive patient identification. And so, again, our respondents were asked questions, and this represents the yes response. Positively identifying a patient at registration through biometrics could improve cash flow for the hospital. 80% believe that to be true, so a very high yes response. Positively identifying a patient at registration through biometrics could reduce denied claims. 76% believe that's true. And then finally, positively identifying a patient at registration through biometrics could reduce days in AR, accounts receivable, at 72%. So clearly our respondents, whether you're a clinician or on the finance side of the organization, see huge benefits, very large financial benefits of positive patient identification. Go to our next slide. And now we're going to talk a little bit about methods. Remember I told you we have a whole bunch of folks in different size hospitals, ranging from large integrated health systems to standalone hospitals, office practices, clinics, specialty clinics, and others. So the largest slice of the pie is the large integrated health system, followed by the standalone hospital. Next slide. In terms of who participated, I mentioned 55% clinician, 45% not clinician. Nurses being the largest slice of the pie, followed by physicians, physician assistants, chief financial officers, chief information officers and their staff, patient access officer, quality officer, revenue cycle officer, compliance officer, chief medical information officer or chief medical officer, risk management. So we cover a lot of different functions within the organization. Next slide. And this is the caveat. It's the warning label that you see on the carton of milk or carton of cigarettes, I suppose. But basically, we really love doing surveys, and they're very rich for collecting data like this. But there are inherent issues or biases that may exist, and so you try to control for it. But there's never a guarantee that you mitigated that particular bias. The biggest biases are the non-response bias. The people who participate are different than the people who chose not to. We try to control for it and measure it, but it still could exist. Sampling frame bias is the bias that your sample is not representative of the entire population. Again, we try to manage that risk, but it's still possible it exists. And then the hardest one is a self-reported result. On a good day, an individual might respond one way, and on a bad day, rainy, miserable day, whatever, they might respond to the same question differently. And we know that, and we basically rely on randomization, the law of large numbers, that basically these things kind of net out, but they could exist in the data. And with that being said, I think it's time to turn it over to you, Christopher.
Well, thank you, Larry. Those numbers are really hit home with me. I do appreciate the study. It does resonate quite a bit, and I want to talk a little bit about what those causes can mean for misidentification, and really how it happens. You mentioned a lot of them. If I can see in the next slide, some of those root causes are actually visible right here when I start speaking about them. If there's a registrar that's rushed or poorly trained, and wants to do the right thing by the patient by trying to get them through quickly, this could very easily have an effect on it. And where's that affected? It affects the patient because they get a record that may not be as quite accurate as it needs to be. And as a safety point, as a clinician, to me, I'm going to get a record that may not have the right past medical history, might not have the right allergies, could very well have had changes in treatment and medicines just days before that aren't visible to me because we opted to create just a new file. And that it's a double-edged sword. We don't want them to create a duplicate or an overlay in the beginning here, but unfortunately, if they do this, they create a blank record. And that could be just as dangerous to give me a blank sheet when I have known medical history, known true health issues that I need to be aware of that doesn't come through in a patient's chart. And that could be a number of different things. It could be a language barrier. It could be someone posing just fraud. I mean, if there's twins and they're using their daughter's ID, or if it's, again, someone just who isn't insured and trying to use someone's card that is. If they have meds that are related to hypertension, and I assume they're taking them, I'm going to give them maybe potentially while they're staying in the hospital. They may not even be on these medications. Those risks become huge errors for the patient, and some of them being, again, a medical error, could be an inadvertent X-ray. A lot of things can happen. So we do need to know and make sure that they do have that correct record. And sometimes it is just a lack of awareness that they could be getting the bad record. Someone comes in thinking they're just going to get free health care and scam the system. They end up causing some more harm. Where this is most evident was here in Harris Health. You can see that they have a very large catchment area, and the whole total is 3 million folks that reside in that Harris Health system database. Now, of those, people that have been named, 2 or more patients share the same last name and first name. It's pretty staggering when you look at 249,000 Maria Garcias. So, you would think, oh, well, that's just a big number. It's in the lower part of Texas. That's a popular name. So you drill down one more and say, okay, maybe they share the same last name and the date of birth. 69,000 people still share those 3 common denominators. And that's really where most healthcare and registrars stop. First name, date of birth, that's where and last name. That's where most people would be picking from 69,000 folks. You narrow that down there. Of those date of birth, last name, with the first name Maria, 2,488. So number of Maria Garcias in this one healthcare system, 231. On any given day, that's what's going to come up from a registrar to choose from. That's a very big chance of a misidentification. And from a clinical standpoint, from a safety standpoint, you need that. This is what they go through as far as a patient identification. When you think about them rolling through the ED, walking through, coming in an ambulance, wherever they present, they're going to come in with their registration, and they're going to ask for some sort of identification. Oftentimes it'd be some sort of a federal ID license. If they come out unconscious, they could very well come in and we do what we call a wallet biopsy. We're looking through assuming that the wallet was actually on the person in this car accident, but looking for a medical card, we're looking for an ID. And most of the times, we don't trust that because we don't have any verbal confirmation. We make them a John Doe, which, again, automatically starts duplicate records. So that's another challenge in itself. I'll get to in a little bit. But they have identity problems right there. So if you have those choices of 4 or more, just go back for 1 second. With 4 or more of those choices to pick from, those people are going to potentially pick a blank record, and that's the risk that I talked about. So where does that mean downstream? The HIM department then has to get that, and they receive that record, and that could very well either be a duplicate or an overlay. And for people who are clinical, may not know the implication downstream that we may have caused by duplicating or making notes in someone else's record. That record now has to be dismantled. And that's a timely process. What that means for the reimbursement for the care that took place, it gets submitted over to the insurance company. It could very well be denied because of the inaccurate billing, names, dates of birth. That means that the hospital's not getting paid. When we're talking about keeping hospitals open and clinics available for folks, we need to make sure the reimbursement is coming through. So, to continue good patient care, we need to make sure the financials are in order as well, and that's a big plus. From the injury standpoint, the next slide will show you that there's over 6% of the folks actually have an adverse reaction of the 10% that actually get misidentified. So as we mentioned in the numbers that Larry brought up, 10% of these patients can be misidentified. What's an adverse reaction could be as simple as I mentioned, the person going down and getting a chest X-ray. Irradiation is not something that we joke with. We want to make sure that we're not irradiating children, and we don't have to. Adults don't need extra radiation. Adverse medications given because someone's wrong name, date of birth, misidentification right from the beginning. We need to stop that from the beginning so that there's no adverse reactions. And obviously, the more detrimental ones, when you have wrong surgeries or death can occur from some of these misidentifications, which has happened. So how misidentification really impacts it? From the clinical side, if we get that incomplete record, we don't know what exactly your history is. So if you're not awake and alert enough to give us that background history, it could be very much a patient risk and safety issue. The things that we like to see is if you had tests that have been done outside or recently in a week or so, a CAT scan, that shows a change or something that we're concerned about. Well, if we don't see that in a record, well, I know as a clinician, I'm going to repeat it because I need to see it. And that means you're going to get another dose of radiation, maybe 3 days, 4 days after you already had it, which you don't need. That could have been easily viewable if we had pulled up the right record. Medications I mentioned, you improperly managed. If I give someone the medication that they're not on, that's as dangerous as someone coming in as an overdose, and that's being caused because someone is just being misidentified. Not to mention, if you're in someone else's record, you're breaching their medical history, as well as showing it to the patient. Oh, this is what we have, and they're like, oh, okay, that's great. You could be breaching PHI right to the patient without them even knowing it. So there's a lot of problems that can come from misidentification. And it could be across both physicians and the patients themselves that you put yourself at risk for. So, as I mentioned, the impact is not just on the patient side, certainly not on the clinician side, but to really think about where it's going to be going downstream as far as the finances. We work on an operating budget in the nurse department that we need to stick to. If we're getting denied claims, that means we're going to be losing more FTEs in the following years as we look at this. It's becoming a bigger issue. So we do need to think about those claims in the duplicate tests that we're doing. In the day and age of macro coming around the corner and ACOs now, duplicate testing isn't going to be paid for. They're going to say, great, they did one 3 days ago. Just because you didn't know about it doesn't mean you're going to get paid for it. That's a pretty big ticket to start, saying, okay, we're going to eat the cost of a lot of these. So you need to be ahead of the curve, make sure that we're getting the proper identification up front so that these claims can be taken on in the right way so you don't have to rework them and rebuild them and have those extended out months and potentially, 2 and 3 months before you get the monies back on these. What that can lead to is a lot of patient dissatisfaction. They're like, if you tell someone's been into your record and used you as the scapegoat and, what do you think that they feel? I mean, that you've breached their medical history to someone else. The distrust right there. Not only have you given away free care to someone you didn't want to, but you've gained that distrust in the patient you did have. So it also is laden with some penalties associated with privacy breaches. Again, that's a HIPAA violation. You do need to report this. If you don't report it, another $25,000 if you don't report it. So, there's some financial problems without properly identifying from the very beginning. And I think at this point, I'll turn it over to Justina.
Thank you, Chris, and thanks, Larry, for your insights. I hope the audience found them very educational and useful. Really quickly, we'll come right back to Chris, but I wanted to share a story about a hospital that had this problem and how they solved the problem. So Carolinas Healthcare is one of the largest healthcare systems on the East Coast within the Carolinas region, and they had about an 8 to 10% duplicate medical record rate, which is around the standard duplicate rate that any hospital would have. And while they implemented an EMPI system or an Enterprise Master Patient Index across their multiple hundreds of hospitals to cleanse and unify patient data, they still resulted with about a 5% duplicate rate. What they did was ended up putting a biometrics platform in front of their EMPI in order to positively and uniquely identify patients. And with that, they've reduced their duplicate rate down to 0.01%. That's not only good for patient safety, but frankly, very cost effective for their organization, as they're no longer spending cleansing costs and everything that they do have to do for duplicates and overlays. Next, they also had check-in times significantly reduced by almost 75%, which is quite a number. By improving that registration experience, they were really able to get the patients into the room faster, to see the clinician faster, and get them out of the hospital faster. So faster turnover and throughput within the organization. Now let's talk about some unique workflows. We talked a lot about registration and how patients can be misidentified at registration, but let's talk about some of the other workflows and some more serious scenarios that could happen outside of registration. So Chris, you're an emergency care nurse. Can you talk a little bit about sometimes what happens in the emergency care scenario when you can't identify a patient and how you've seen some organizations solve that problem?
Sure, I can. So I work at a level 1 trauma center, and we do get a lot of trauma sent in there, a lot of them unconscious or on a ventilator and can't speak to us. So that unconscious patient, we'd love to be able to identify, but oftentimes has to come in as a John Doe. And working on a busy Friday or Saturday night in Boston, you could have 4 or 5 or 6 John Does in your hospital at one time. Very popular name here in Boston. But you want to make sure that you're not confusing the John Does amongst themselves, as well as each and every one of the medical information. So if you get some sort of biometric would be the exact answer that you're looking for, because you can tie that biometric to that patient's record. So then that John Doe would actually be somebody. So if you could do that, that would be wonderful in regards to that unconscious patient. The trauma search capability for that person and pinning it down to the right record would just, again, streamline all the right medical treatment being done for them and all the downstream financials that we talked about earlier, and the huge benefit in that regard.
Thank you. Thanks, Chris. And another workflow here, point of care. So let's say you properly identify a patient at registration, but then they go to the point of care. They may be getting medications, or they may be about to get radiation or get a blood transfusion. What are some of the risks there, and how can those be prevented?
Sure. I've seen some places do lab point of care testing so that they can do it there and identify them before they do it. Certainly, radiation oncology, some of the treatment there when you're talking about the radiation dosing that you're getting is astronomical. I mean, it's to kill a cancer treatment. So the dose of radiation that is given at that CyberKnife or at the accelerator is a very high dose. So you want to make sure at that point, absolutely, you have the right patient, because that can something go really wrong if you're giving that to the wrong patient or the wrong area or the wrong dose. So having positive point of care verification there that ties it to the record and actually pull in what the dose is and who it is, that's phenomenal. That's what's going to save a life right there.
Excellent, thank you. And to add to that, for those that are interested in some more information around this, the ECRI Institute recently released a report which really highlighted some of these issues that can happen from misidentification. And some of the examples that they cited, they had a scenario where a cardiac patient was mixed up with another cardiac patient, and their DNRs were mixed up, and therefore the wrong patient was resuscitated and the wrong patient died. Or something as simple as potentially, the baby getting the wrong breast milk from the wrong mother and getting sick as a result of that. So I encourage everybody to go ahead and check out that report, which is available online as well, that has a lot of great information around this. Next, let's talk a little bit about how folks can solve this problem, and then we're going to go straight to Q&A. So again, if you have a question, please go ahead and enter it into the Q&A panel on the bottom of your screen, and we'll take all questions for Dr. Larry Ponemon, Christopher, and myself at the end of the presentation. But first, let's jump to another quick poll question. Is anyone in the audience currently investigating biometric patient identification solutions? The responses are yes, we're researching, yes, we're evaluating, no, we already have a solution, or no, we have no plans. So go ahead, let's give the audience a few minutes to go ahead and take that poll, and then we will jump right into Q&A in a few minutes. Great. Well, it looks like quite a bit of the audience is researching solutions, and a number of them are evaluating, and then there's a plenty large group that still hasn't made it there just quite yet. So thank you for sharing your insights there. We really appreciate that. And let's just jump to really quickly what a biometric identification solution is. This is an example of a positive identification platform called Imprivata Patient Secure, which is provided by Imprivata. And it really leverages palm vein biometrics. There's a number of different biometric modalities that can be leveraged to identify patients. However, palm vein biometrics is great because it's non-intrusive, very easy to use, and doesn't have any type of forensic value or connotations or fear amongst patients. And this solution can do everything from positively identify your patients at registration, which was highlighted by Dr. Larry Ponemon as the #1 reason that patients get misidentified. It can also identify patients at the point of care. So once they've gone through registration and they're about to get a blood transfusion or go through radiation treatment, they're able to be verified that they are that person that actually was checked in. It can also be used for unconscious patients. Many patients are either unconscious, incoherent, they don't speak English, they're lying about their identity. A number of different issues can happen in that scenario. And with that biometric modality, you can really ensure that the person that is in front of you, whether that's John Doe or someone that's saying they aren't who they are, is the right person. Many organizations are starting to implement self-service kiosks for check-in experiences where they're collecting copays and insurance information for patients when they come into the hospital or the clinic to better get them through and get them to the room faster. This is a solution that can be fully embedded within that technology. So that's something definitely to look at if you're looking at kiosks. And lastly, it's fully integrated with your registration system, EHR system, or EMPI system. So this is really something that you can plug on top of your EMPI in order to ensure that you're positively identifying every patient that comes through the door. With that, let's go ahead to Q&A, and I'll pass it back to the folks at PSQH.
Well, thank you to everybody, to all of our presenters today for sharing all the information with our audience. I know it was very educational, very useful information. So this does bring us to our Q&A portion of the program. And again, we would like to ask all of our audience, if you do have a question, to go ahead and submit it at this time. And as a reminder, the way to do that is to click on the red Q&A widget at the bottom of your screen. Again, it may already be open and appear on the left side. Again, so that please note that your questions will remain anonymous and will not be viewable by other audience members. Before we get into some audience questions, just, what I'd like to do with you real fast is, looking at your last poll question there, you see answers across the board. And one of the things I think I might want to ask, just to kind of get the process started, is if somebody was looking to implement any type of a patient identification type of a solution, where should somebody start? I mean, that's kind of the big thing.
Yeah, no, that's a great question. First, many folks start on Google and just looking at solutions there. There's a number of different associations, such as AHIMA, HFMA, a number of organizations like that have a lot of information. There's also a ton of information on our website, imprivata.com, that actually provides, examples of hospitals that have gone through this. I would say if you're looking at this technology, talk to someone that's been through it. This is a very complex problem to solve, but there are definitely solutions for that. You can reach out to us at Imprivata in order to get connected with someone that solved this problem, such as Carolinas Healthcare or others, and provide some more information for that.
Perfect. And Larry, I know we have a couple of questions from the audience, but I'd like to address something to you. Your report was very robust. It looked like there were a lot of people that partook in the survey itself. So I want to go back to the report real fast and kind of ask a very brief question here. You look at all these statistics and all the questions to the answers and how those all played out. Was there anything that stood out to you in either let's do two-part here. Was there something positive that stood out to you and then something that shocked you that you would have thought would have been something different than what the outcome that you were expecting?
Sure. In general, I'm a researcher. I'm not a clinician. But just the rate of misidentification was just so much higher than I anticipated. I mean, as a layperson, to the healthcare industry, you don't think that that's such a huge, pervasive problem, but it seems to be a very, very significant problem. And the other, I think, finding that was surprising on the financial side is just the sheer cost to the organization. Misidentification means that you basically get a denied claim. You have to rework the claim, and that could be very costly for an organization, or you may never collect on the claim. I mean, so the potential is not just hundreds of thousands of dollars, but even millions of dollars, I suppose, for larger healthcare organizations. So I think those are two areas of surprise. Now, on the positive note, the general consistency of our practitioners basically seeing the benefit of a positive identification system, using biometrics. It's consistently high, in all the different segments of our sample. So, that is, I think, a very positive result.
And Chris, I'd like to maybe address something to you here as the clinician that sits in the trenches each day. How does utilizing proper patient identification and not only enhance your workflow and procedures, but also the overall patient experience for the person that you're dealing with?
Sure. By tying a biometric and giving me their medical record, as I mentioned before, it gives me the insight to what their past medical history was, their medication list, and I can start to formulate a good treatment plan along with the clinicians that I work with side by side with the right information. I think that's great for the visit that we have. It could be, that have started identifying them in the doctor's office and they benefit when they come to the hospital. I certainly think the other thing from the patient is when they come back a second time, there's no reaching in for a wallet anymore. Looking for a medical record, your medical card, your ID, you place a biometric palm print down and be immediately put through. That re-authentication coming back in, you see customer satisfaction up. I mean, people are no longer spending 20 minutes at registration. They're spending 1 minute at registration. When you can replace a lot of that wait time, that downtime that they view as not being seen by a clinician. And now you can get the patient from the door to a clinician quicker without any barriers. That's a huge win for the patient. I do think that's a big take home for them.
Okay, and to build off of that, one of our audience members asked, how do patients react to those biometrics when they're first introduced to them? Because that's obviously not probably a normal procedure most are used to when walking into a facility.
Sure, I can take that question, Jeff. So it's a very valid question, and it comes up all the time. Many organizations, kind of your natural assumption is that patients will be afraid of biometrics because, they've seen CSI and all the forensic issues and things like that. And that's really why picking the right biometric is really important. So there are different modalities out there. Fingerprinting is an example of one. Many patients are concerned about fingerprinting. They don't understand why they would have fingerprinting is something you get done when you go to jail or go get arrested, not something that you do when you want to get treatment at a hospital. And it has forensic value. So there's concerns around that. Iris scanning is also available. Some patients react negatively to that because they're afraid of just how invasive it is and the forensic value of that as well. Palm vein biometrics is something that is very non-invasive. It's not something that's used anywhere else for any other type of identification, positive or negative, on the market. And what's interesting is once you explain to a patient, this is something that is protecting your identity, making sure that not only does the clinician have the right chart, but it actually is protecting you from identity and insurance fraud. Patients are so concerned around someone stealing their social security number. They have to walk up to a registration desk, say their name, their date of birth, their social security number. Everyone around them can usually hear them. It's very invasive, and people are very concerned about that. All you need is that information to steal someone's credit card or medical identity or anything else. And this type of technology, once you explain to a patient, you never will have to bring an ID again. You won't have to tell everybody your social security number again or your date of birth or your name, et cetera. And if someone tries to use your identity, they'll be blocked from receiving care under your identity. So that's something that patients often find very, very, they're very appreciative of that, and they really see the hospital as doing something for them. We've had patients that literally have gone to local news media stations and said, you've got to go see what they're doing at that hospital at XYZ, because of how impressed they were with the fact that the hospital was doing something for them. Now, there's always going to be a percentage, 1-2% of patients that just will not partake in technology, whether that be for religious reasons or other reasons, but you're still solving the problem for the larger, broader population that will accept it very well.
You actually brought up a very interesting point there when talking about that process, and I think the big thing is security. Can you talk to the benefits of having this type of situation and technology in place that makes the patient feel more secure throughout their stay or their visits to a certain facility?
Sure. No, absolutely. I mean, from a security perspective, as I mentioned earlier, particularly we have a number of customers in Florida or areas where you might have an aging population. And senior citizens are one of the largest targets for identity theft. I'd actually love to pass it to Larry after I finish responding around how large identity theft actually is. But whether it's identity theft or insurance card sharing, those are huge, huge issues. And lots of senior citizens, they don't want to have to explain what their social security number is when they go into the hospital. So this really prevents them from doing that. On the other side, from a security perspective, this is something that the hospital can do to protect all of their patient identification, patient records. It's something that's housed locally on premise within the hospital, fully encrypted, and something that really protects the hospital as well. Beyond that, from a security perspective, when you look at security and policies, this is something that is fully audited. So many hospitals that I've spoken to have been in situations where someone's identity was stolen or someone received care, but they denied that they received that care. And they had no evidence that that patient was actually there on that day at that time to receive that treatment. By using a technology like this, you're able to fully audit that you 100% had that person at your organization at that time and fight any type of legal claims that may happen. Now, Larry, I'd love to ask you, you've done a lot of reports around identity theft in healthcare.
Sure.
Can you talk a little bit about what you've seen in the market around that?
Yeah, so, for the last 5 years, we've been doing an annual report on medical identity theft, which is a subset of all identity theft crimes and probably the most expensive. It's a crime that's committed by people who may, seal your credential, your health ID, for example, your social security number. They go to their clinic or hospital and they get services like cosmetic surgery and, all of these very expensive procedures, or they get equipment, from I don't know, scooters to to implanted devices, whatever. The cost to the healthcare industry is enormous. In fact, in our last study, there were well over 2 million incidents of medical identity theft over a 12-month period. Now, positive identification solves a lot of the problem. Not all of the problem, but a lot of it, because you can't say, I'm Larry Ponemon when you're not, or Justina, you know what I mean? You basically are who you are. And using that technology would basically be reduce the rate of medical identity theft, in my opinion, but it would also reduce the costs associated with medical identity theft. And that cost is borne by the healthcare organization, but society as a whole. We're paying more for healthcare because of these fraudulent acts. Thanks for asking.
Thanks, Larry. Yeah, and just one last thing to add around security. In a medical identity theft situation, if someone's stolen someone's identity and they're treated in the hospital under that identity, and then the hospital sends a letter or any PHI to that person that's stolen the identity, you now could have a HIPAA violation on your hands, because you're sharing PHI with the wrong person. So HIPAA is a large concern in these scenarios as well. And what's funny is that every time we deploy this type of solution, a biometric solution, to a hospital, generally the first phone call we'll get is from their neighboring hospital, because all of their fraud, frequent flyers, and insurance card sharing will stop and go to the closest geographically neighboring hospital, because folks know that they can't do it anymore. So it's definitely something that we see all the time.
Wonderful. Larry, I want to go back to you. We have time for just a couple more questions. So, Larry, looking at some of your studies here, in terms of the people that actually responded to your survey, it looks to be about 42% were the nurses or the physicians assistants, so the people that are in the trenches. When it comes to implementing such a strategy in a technology, do you see this being a top-down approach or an approach that starts with the folks that are in the trenches every day?
I think top-down is important. It sets the tone. This is an important issue that can be resolved, at least in part, with better technology. And so I think you have to have executive-level support. And then, obviously, in terms of its implementation, it only works from the bottom up. You can't get to the C-level executive to actually start installing a new technology. So you expect your clinicians, your nurses, doctors, and others to basically be involved in the implementation. But these kinds of technologies, it does require an organizational commitment. And sometimes you see organizations implementing technologies in a piecemeal fashion simply because they don't necessarily have executive level buy-in. So I think that's where it has to start.
Perfect. And then it looks like this will be our last question for the day. And Chris, I'm gonna pose this one to you. Somebody from our audience asked, how would you prevent the patients providing false information when entering care?
Sure. Well, in current day state that everyone's used to is they usually present to a clinic or a hospital or to an emergency department, and the first thing they're asked for is identification. And oftentimes, if you can tie that to a government issue like a driver's license or a government ID, and assure that patient is the person who they say they are with visual confirmation, that's certainly one thing. And for people who think that's a big to do, if I prescribe narcotics to the patient and they go to the pharmacy to pick it up, they need that same license to pick up that medication. So it's something they're used to, but if they only have to take it out at the pharmacy to prove who they are, and they can replace that with a biometric, so that next time they come in, that biometric is that identification, you tie that to that person and that identification, that eliminates that step. So I do think that's a great way of stopping some of that false identification being put forward, because you're going to tie it to a photo ID and that initial onset when you tie someone to a biometric, which is again I think is a huge piece. I just want to echo what Larry said a second ago. It is technically it might be a C-suite buy or a registration helping with the project, but it's a team approach because there's a lot of benefit for the hospital, the HIM department, as well as the finance department. And the people that they really get the benefit is the patient. And the patients get through quicker. The clinicians get a safer chart to treat them with, and it's a safe, clinically sound process if you can guarantee that that's the right record. So there's a lot of wins, but it's got to be a team approach to take it and to bring it over the line and get that win.
Great point. I agree.
Well, that is all the time we have for questions today. I want to, again, thank everybody for their participation. In closing, we want you to know that your feedback is very important. As seen on screen at the bottom of the current slide is a link to an evaluation. A live clickable link can be found in the resources list as well as in the program evaluation widget at the bottom of your screen. It'll also appear in the slide window at the conclusion of the program. We would greatly appreciate your thoughts on the program today. I would like to thank our speakers once again for joining us today and sharing their knowledge on this topic. And to our listeners, thank you all for putting aside so much of your valuable time to watch our program. We hope you found it informative, and we look forward to providing you with other helpful programs in the future. Ladies and gentlemen, this concludes our program today. Thank you again for joining us, and have a wonderful rest of your day.
Thank you.